Welcome, everybody, and thanks for joining us tonight as part of another installment for the AO Trauma North America Journal Club series. Tonight, we will be covering pelvic ring resuscitation specific articles. We've got 3 good articles, a loaded panelist and author collection for you all today. We're very excited. Hopefully, we'll garner a bunch of interest, some questions, some interaction, and obviously learn a lot. I am the chair of this journal club, Lucas Marchand. Thanks again for joining us on this Tuesday night. So here's a look at the moderators tonight. Obviously myself as the chair, we have Dr. Size, Dr. Kellum, and Dr. Working, who will be conducting interviews for the articles we selected. And here are our faculty authors, Dr. Rout, Dr. O'Toole, and Dr. Perry. I saw everybody prior to the starting or kicking off the meeting, so everybody's here tonight. So we should be able to get everybody's questions answered and really kind of dig into the nitty-gritty of these articles. Here is a list of disclosures for the evaluator, obviously all of the moderators, as well as our author faculty. And one more slide here. And that brings us to the disclosures for the AO North America. You'll see here that the foundation receives education from Synthes, and all rights for these educational resources and assets are used and owned by AO North America. We're very grateful for them hosting this forum for us all to learn through. This has been an extraordinarily popular endeavor for them in terms of this journal club, and it's been very successful. AO North America is an independent nonprofit surgical specialty society dedicated to improving the care of patients with musculoskeletal injuries. They do not endorse or promote any products, services, or commercial entities. They are independent. Equipment used for the purpose or shown for the purpose of this journal club is there to enhance your all's learning experience, but not necessarily to promote. Feel free to type in any and all questions. That's what we're here for. So here's a quick look at the agenda. We'll do the intro. 5 minutes in, we're going to go through the first journal article, Open Fixation After Preperitoneal Pelvic Packing and its Association with Surgical Site Infections by Dr. Working and Perry. Then Pelvic Ring Injury Mortality, Are We Getting Better by Dr. Kellum and O'Toole. And then Circumferential Pelvic Anti-Sock Sheeting, a Temporary Resuscitation Aid by Dr. Size and Rout. That'll get us to about 8:15. That'll leave us 15 to 20 minutes for questions, and then we'll wrap up. Learning objectives are to review classic and current journal articles in pelvic ring resuscitation. We want you to be able to explain how this literature advances the treatment of these injuries and what has changed over the course of history, identify best practices based on science, and then participate in a live discussion. And with that, I'll end the slideshow and we'll get into our first video.
Okay, thanks for everybody for being with us. I'm Zach Working, and I'm here tonight with Josh Perry. This is the AO Journal Club. We are going to give you a little rundown of a paper that Dr. Perry has been involved in as the senior author on. This is a journal article that's coming out in the Journal of Orthopedic Trauma. The title of it is Open Fixation After Preperitoneal Pelvic Packing is Associated with a High Surgical Site Infection Rate. The article is fascinating. We're going to talk a little bit of history tonight. If it's okay with you, I'd love to give a little rundown, just a brief little summary of the article, if that's okay with you.
Of course, thank you.
Okay, all right. We really appreciate you coming and joining us from Denver Health tonight. Okay, so basically, this is a retrospective review of a prospectively collected database looking at patients with pelvic ring injuries and comparing a group that received preperitoneal pelvic packing for hemodynamic instability management and then subsequently got fixation of the pelvic ring versus patients who received also fixation and did not have to get any kind of preperitoneal pelvic packing for hemodynamic instability management. The centers, it's an urban level 1 trauma center. That's at Denver Health. The very salient dominant finding here that we're talking about is that the surgical site infection rate in the packing group is just north of 30% compared to just north of 10% in the control group. The authors ended up doing a propensity score matched analysis in order to try to take away some of the challenges of analyzing patients of different severity of injury by looking at differences in ISS and ASA score for matching. And with the propensity matching, there remained a significant difference with fairly preserved infection rates. And so I think, probably the right place to start here is to consider a little bit, what is the history of packing? Why is this interesting? And why is it particularly interesting for your center?
Yeah, so due to our slow angiography or time to get angiography at our center, back in 2000, they began doing this preperitoneal packing program. Now, the idea behind that was you can gain hemostasis quicker in these patients who were dying of exsanguination. And, that has been going on since the early 2000s at Denver Health. And in 2019, we published a paper showing minimal infection risk with preperitoneal packing. But I came to the center around that time, and that has not been my experience, which prompted the study to look at what is the real infection risk after pelvic packing. Because obviously it may be life-saving, but if it ends up in pelvic osteomyelitis, it's something that we should be careful about.
Yeah, that's a challenging problem to solve, and practically just as challenging all the rest of it. So long history of pelvic packing, done pretty successfully. Denver Health has obviously written a lot about this topic, and then you arrive in a higher than expected infection rate. And then it turns out that this is a difficult analysis to pull off. It's sort of, talk to me a little bit about the challenges of selecting a control group in this setting.
Yeah, so just like the previous study, the control group is just patients getting anterior open reduction, internal fixation of the pelvis. Obviously, there's going to be significant differences in these. The injury, the packing group is going to be more severely injured, getting more packed red blood cells. Everything is going to be at higher risk in them. So we did attempt to do control for a little bit of this with propensity matching, and we were able to get two groups that had the same ISS scores and ASA classifications, which I think able to correct for some of it. However, the group still had significant differences in blood loss or packed red blood cells and differences in getting Reboa. So they're still significantly different groups. So there's no fixing that, but I still think the finding that 30% infection rate in that group is higher than the previous infection rate of 8% that we reported on, and is notable.
Yeah, it's so interesting, right? Because if you were going to design a randomized controlled trial, you would basically randomize people at the point that they were so sick that they needed hemodynamic management, and you would sort of then randomize them to two different pathways. And, certainly like that seems a very pie in the sky sort of thing. That's kind of hard to randomize at the point of, sort of extreme physiologic problems, not only difficult to pull off, but also, would really restrict your ability to sort of like measure the things that you needed.
Yes. And maybe even morally dubious too. And
certainly, yeah.
Crashing, and the general surgeon thinks they need pelvic packing to survive. It's going to be hard to randomize that cohort.
Yeah. Hard to randomize against survival concerns. I agree with that. I feel like propensity matching has gotten a lot of notoriety in the past couple of years. I think we see more and more papers coming out of the Journal of Orthopedic Trauma with propensity matching as sort of the matching technique. I'm guilty of that also. We have a paper coming out soon with the sort of a similar technique. Why do you choose that instead of some other matching technique?
I think the ability to get two groups with similar, or mostly similar in this case, differences in characteristics is powerful and more convincing than maybe our prior ways of just doing a retrospective analysis with no matching, or even the traditional 2-to-1 matching. So just getting two groups with no significant differences in those characteristics is, I think, just a better argument.
Yeah, I heard someone refer to it almost as if it was like a thoughtful matching rather than a random matching, and that really had some appeal to me, that there was some reason that people got picked rather than just sort of like they were the, you know, next up in the 2-to-1 or 3-to-1 strategy kind of.
Thoughtful matching is a great way to put it.
Yeah. So there's a really interesting secondary finding in this paper, which I latched onto immediately, and it's even going to affect one of my patients tomorrow, is that you found specifically more infections. It's not just more infections in the treatment pathways. You also found more infections in patients who'd received open reduction internal fixation in the anterior ring, in patients who'd been packing, compared to patients who'd received packing and then ended up with an external fixator for anterior ring control and management. And the numbers aren't small. It's like, again, it's a little bit, you're dialing down into subgroups, but it's like 45% versus 11%. And I'm curious if you guys were surprised by that, or is that really what you guys have been seeing a lot, is the terms of the consequence of packing? Maybe that's why you started the study, and like what's changed since then?
Yeah, so obviously found a much higher rate. That was really one of the most significant predictors of infection in the packing group, was getting a plate afterwards. And just anecdotally, our group, if someone gets packed, we're very, nervous to go in there and take those laps out and put in plates and screws, because it does seem like the infection risk was notable. And so what has changed, we brought this data to our general surgeon or the trauma surgeons, and we've actually changed our protocol. So we have a higher threshold to perform pelvic packing now, and that's been in place for about a year. So prior, it was 2 packed red blood cells. If the patient is still hemodynamically unstable, they would go for packing. And, maybe that was a little too low of a threshold, so that we're now at 4 units of packed red blood cells. And in the past year, we hadn't done any pelvic packings. So we've definitely dramatically reduced the number of pelvic packings we're doing based on the findings of this study. And, ongoing studies to see if that has impacted our mortality rates. But we think so in time.
Yeah, I for one will be fascinated to see sort of what the overall, sort of like life cycle changes result in. You guys are a very interesting and fascinating test case, and I've always thought that. One of the last things I wanted to ask you about in the paper, there's some mention of the use of REBOA at your institution, and which is an interesting thing. I feel like REBOA is another one of those buzzwords in pelvic resuscitation. There was sort of a time where we all thought that was going to be the next big thing to control these patients in super extremis. And then there was a paper by Marchand et al. That came out in the JOT that talked about like the really extreme rates of complications that came from that. And I'm curious, is this a thing that happens commonly at your institution, or is this kind of a couple of one-off sorts of things? It seemed like there was some in your cohorts.
No, it was being used extremely frequently now. And we have another paper that we'll be presenting a poster on at OTA regarding the complications and mortality rates with REBOA, that we also did propensity matching. It has the same limitations, meaning we can't get perfect propensity match groups because of, these patients are the worst of the worst, or in extremis. Our infection rate was lower than that of Marchand et al. But the mortality rate in the propensity match group was similar. So I think there's still, it has significant morbidity. It should be safe for those, much like pelvic packing or crashing, and extremis.
Mm-hmm.
But
great.
I think common. So that data will be interesting once we get out there.
You said a poster at the OTA.
Yes.
Awesome.
Right next poster. So.
Yeah. Hey, I think that covers it. I think that's a really, fantastic review of the ins and outs of your paper and sort of the history and sort of why it is a compelling paper. And I would urge everybody watching tonight to take some time and read this. And then read some of the other things that Denver Health has published. I think it's really great to have a center that is willing to kind of push the limits a little bit and do some exploration. Not everybody has the same scenario at their institution. Some people have better access to angiography, some people don't. And I think that ends up producing innovation, and it's great that you guys are willing to share your findings from that.
Thank you, Zach. Appreciate it.
Sweet. Okay, we're going to wrap up on that. And thanks.
Dr. Bob O'Toole from the R. Adams Cowley Shock Trauma Center in Baltimore, who's a senior author on the paper Pelvic Ring Injury Mortality, Are We Getting Better? Just published in JOT in 2022, and we're going to talk about tonight. So I'd like to thank Dr. O'Toole for joining us. This was a retrospective review of over 3,000 patients with non-operative and operatively treated pelvic ring fractures, and grouped into two time frames, older time frame and a newer time frame, to look at composite in-hospital mortality rate. And they found that the newer time frame, or patients that were treated between 2007 and 2018, had a lower mortality, in-hospital mortality rate than those that were treated between 1999 and 2006, which is a previously published cohort. So Dr. O'Toole, what do you think the biggest findings of this paper is for people that are reading it?
Yeah, I think you kind of hit it right there, that, you know, unlike other things we had done, and when we did that previous paper years ago, we sort of showed like, hey, we didn't make any improvements. You know, it's the overall mortality hasn't seemed to change much. This did, and you know, we had a paper on bilateral femurs comparing it to the Carol Copeland paper from years ago, saying, look, you know, the death rate of bilateral femurs dropped, but that dropped because bilateral femurs have gotten less severe because of maybe airbags, and you know, you don't get all these thoracic injuries from bilateral femurs like you used to back in the day. That's not the case here, because actually, when you control for confounders, so things that are associated with death, in this patient group, it actually makes us look even better. Like we're improving even more over time when you do some advanced modeling. So it's not that the patients are getting less sick or less severely injured. If anything, they look worse in this patient cohort over time. So something, you know, it's not a randomized trial, but you know, it looks like there might be a signal here, and it's pretty sizable. You know, it's kind of just cutting the death rate in half in this patient group, that maybe something has changed in this time period for the better.
Yeah, and I think that was one of the strengths of the paper, was the subgroup analysis that you guys looked at and controlled for different patient injury factors, as well as the classifications. And you found that like you said, that the rate that in-hospital mortality rate was even better if once you controlled. So what do you think there's one thing that we have that you guys are doing that caused that, or is this a multifactorial change?
Yeah, we of course don't know, which allows you to just make stuff up and say whatever you want. I mean, the one, there's a bunch of things that have changed, which we can talk about, but one that temporally lines up the best is the change in resuscitation protocols. And so that seems to be when it happens. We've changed a bunch of stuff in our center, as other centers have too, over this time period. But a lot of those sort of happened after you see the dip. You know, if you kind of look in the paper, there's kind of like a death rate by year. There's kind of a sort of obvious dip at one point. And a lot of the, you know, having the vascular multi-purpose room and all these things, Roboa and all these things we're doing, those all kind of happened after the dip. So, yeah, they may be playing a role, they may be keeping us down, but maybe just the change in how resuscitation is done and TXA and things like that are actually, maybe that's what's happening.
And can you just touch basically on what you mean by, for the folks listening, the change in resuscitation protocols, how that changed? And I think touch a little bit further on, you have a unique perspective because you trained there while that first paper was published, and now you're an attending during the second cohort, and kind of share your perspective on how that's changed in the resuscitation protocols for patients with these injuries.
Yeah, and so obviously I'm, you know, speaking well out of my area of expertise. I don't resuscitate anyone, right? But so
yeah.
What my trauma colleagues,
any of us on this call do that.
So it gives us freedom again to just say whatever we want. But so my understanding is the big changes are permissive hypotension, right? So they're more willing to let people be a little hypotensive, which is thought to be better, and a reliance on a change, you know, getting away from saline and trying to do whole blood, right? So trying to mimic whole blood, so 1-to-1 ratio or to 1 ratio, or actually giving whole blood, and then TXA, early TXA use. And so those things changed around the early 2000s, and certainly at our center and other centers nationally. And that's kind of when you see that dip. And so, you know, we're not orthopedic surgeons, right? Like we're not the experts in that. We're not in North America, although in other places, right, the orthopedic surgeon is the trauma surgeon. So there's more of a combined role of that person. But I think it's important for us to have some idea what's going on with that. And that has definitely changed over time in different countries and different systems have different philosophies about that, about, should we be flooding the people with saline? Should we be making them up? How low can their blood pressure be? There's definitely different strategies.
And I think Reboa is an interesting thing to touch on briefly. There was an initial love for the idea of Reboa, and then I think there was some of those papers that came out of the downsides of using it. Have you noticed in your center that this is something that's continued to be used, or there's now used with caution and it's kind of just extreme circumstances?
Definitely used. So Reboa we were an early adopter and we still use it. I think some of the complications, and I've never put up Reboa, but the complications of it have decreased because just the catheters are smaller and the technology has gotten better. That thing can go up fast. There's some relatively convincing papers, and in someone where your options are cross-clamp the aorta by cracking their chest or putting up a Reboa, that you probably should put up a Reboa. But of course, there's a possible complication of hemipelvectomy or getting an amputation. And so if the patient was going to die anyway, and now they have a better chance of living, that's a good trade. But if they were going to be fine, then that's the argument. It's like, well, wait a second, now if you're getting amputations, that wasn't such a good trade. So as the complication rate drops, of course, because the technology and technique get better, then you're going to maybe widen your indications. And so zone 3 Reboa, so that is Reboa below the renals, that you're going to use in pelvic stuff, is definitely something that we use in the hemodynamically unstable pelvis patients. If you come in here, hemodynamically unstable pelvis, we can our system can get a Reboa very quickly. We can get angio, even though we get angio much quicker than we did years ago, you're still talking, it's not 10 minutes. They can get a Reboa really quickly. And so it's interesting, right? Like the first step is close reduction. But now sometimes it's like the first step is Reboa. They're like, we'll just cut off the blood supply to that region. Why are you close reducing it? Get out of our way. We got to put the Reboa in. So it's interesting, right? When you have a tool that can like cut off the blood supply to the pelvis, it makes you wonder, right? Like, well, what is the first step in this patient?
And so taking that a step further, what do you think the first step is? We've all been taught put a sheet on the pelvis, kind of close reduction. And that seems like it's associated with less risk, though it's still not risk-free. Do you see a shift in the next 20 years where that's going to be the case, where Reboa just becomes that powerful? Or
yeah, in England, right, in London, they've got it on. My understanding is they have it on the, at least there was a time period, I don't know if they still do, where they're experimenting with putting it on the EMS providers and having, doing it out in the field. We don't do that still. Our first step still is close reduction, where a binder placed on a sheet place, but then they come in with binders often now on the EMS, which is true in a lot of centers all over the country. But it is interesting. They're kind of together, right? Like we're like, wow, this patient's tanking. We got the binder on. We gotta get the Reboa.
For sure. Can you talk about why you guys used in-hospital mortality as your primary outcome in this study?
Yeah, we didn't really have another easy choice to do it. Like we just finished the prevent clot study, totally different study, but the primary outcome there was all-cause mortality, a big randomized trial, right, on Lovenox versus aspirin, and that used all-cause mortality at 90 days or whatever. And so a lot more work to get that. So now you're searching death indexes and using these techniques for recording that you got a traffic ticket and therefore you were alive at that time point, and all the stuff we did to try and find out, people who were lost to follow-up, were they dead or not. The nice thing about inpatient mortality, which is why it's used a lot, it's just easy, right? It's recorded in the database. It's a retrospective unfunded study. There's your answer. And so, yeah, you're right. There might be other outcomes, 30-day, 90-day, 1-year mortality, but also inpatient mortality. If you think about, this may not be true, but if you think about what is likely mortality that will be affected by stuff we're doing right away, putting the binder on, like you sort of think, well, that's probably not less likely to be influencing death at 9 months, which might be, from whatever.
Yeah, for sure. And I think that's the strength, is that this is, I think, as true as you can get to resuscitation affecting outcome would be in hospital mortality. Again, 3 months probably doesn't matter what your hypotension was on day 0. Have you seen that this has impacted your center at all, this study? Have people changed practices or been more likely to do something there, or other centers that you've heard of this paper? Or is this more of just kind of letting us know that these changes in pelvic ring resuscitation are helping people?
I think it's mostly the latter. I mean, we often, publish papers that are like, oh, we suck. It's like, okay, right? And so this is like some paper like, maybe we're actually doing something that's helping. So I think that's kind of useful. And says, well, maybe we should, keep pushing it. Like there's some potential to lower pelvic ring mortality. So maybe we, this stuff that everyone's talking about, maybe it is doing something good. So I think that's it. I don't think it necessarily has influenced us what we're doing, but it has encouraged us a little bit that like, oh, maybe we should, I don't know, maybe we can drive it even lower, keep pushing.
And to go off that, what do you think the biggest improvement that we need in pelvic ring resuscitation going forward is? What changes can we continue to make to drive this in-hospital mortality rate even lower?
Yeah, I mean, as Dr. Marchand cited in this paper, if you look at pelvic ring mortality, if you control for other injury factors, it about doubles your death rate. And so it's real, that's something. Head injuries, it's like 17 times.
Yeah.
So the driver of death in trauma patients is not pelvis as much as we'd like to think about it, because we're pelvis people, right? It's like closed head injury. And these pelvis patients die a lot because they have head injuries. They have other stuff. It takes a lot of energy to rip your pelvis apart and bleed, but then you also get other stuff. And so I don't know the answer to that, right? But it may be in some other field of it. But there are definitely confusing patients, and you have patients with, we all see them all of us at our centers with persistent hypotension and displacement of the pelvis, and they're in a binder and they kind of look okay, and the Reboa's been up for a while, or you don't use a Reboa, and the angio came in, they didn't see anything. I do think the decision process of like, well, what should we do next, is tough. And what is the role of pelvic packing in a closed pelvis? Should that be done or not? We do some of that sometimes. I do think there's still a decisional uncertainty for all of us, as to what is the next step to do in these patients that are refractory to the first move that you make.
For sure. And then lastly, I just want you use all-cause mortality. Do you have a sense of what you kind of touched on it, the head injury, closed head injuries are kind of a big driver of mortality. Do you have a sense of what these people are dying from? Is that what it is, or it's just all over the place and it's hard to kind of say?
Yeah, I don't. And obviously, this issue came up a lot in COVID, right? When they're like, well, what did they die of? Or did they die with or from COVID? And so again, mostly not through this study, but actually that prevent clot study, we got more experience about that because we had adjudication committees trying to figure out like, well, what did the patient die? What was the reason they died? And when you look at these patients in a longer term, most patients die for I have no idea. I found them at home and they were dead.
Yeah.
So I don't know. Right now in the hospital, it's hard to figure out for another reason, right? Is that they have a PE and they're septic and they have ARDS and they had a head injury and then they had all this stuff and then someone withdrew care, right? And you're like, well, what did they die of? You're like, I don't know. They died of all that stuff,
Yeah.
So it gets tough, right? Because these multi-system patients have multi-system problems that are lethal. And so the bottom line is we didn't look at that, to my knowledge, unless Lucas said we did, but I don't remember us looking at that.
Yeah.
If you did, I bet it would be a big quagmire, right? You would get in there and be like, I don't know what's going on here. So it's hard to tell, like, did they die of hemorrhagic shock? It's like, well, they got 20 units of blood when they came in and we got their blood pressure up and then all these other things happened, but that didn't help. And then they went into ARDS and they died of their lungs. Well, is it because they were shocky and you had to give them so much blood and their lungs had problems?
Yeah.
Hard to.
Well, thank you so much for taking the time to talk to us about this paper, and we're going to get back to the other papers and the discussion later on.
Sounds great. Thanks a lot for having us, and I appreciate it.
Thank you.
All right. Hi, Dr. Rao. Thank you for joining us for this AO webinar talking about pelvic resuscitation. You are obviously an expert and leader in this field of thought, so appreciate you taking the time. I just want to highlight. Yeah, of course. So I just wanted to highlight basically what I thought were three landmark articles you came out with kind of in succession starting in the early 2000s, talking about sheeting, anti-shock screws, and how that sheeting can be applied with anti-shock screws and other types of fixation. Just for the participants, I'm going to show some examples that are from the articles you all have, but just for reference as we talk about this. All right, so the first article, the screen's loading right now, is talking about circumferential pelvic anti-shock sheeting. So this was published back in 2002 in Journal of Orthopaedic Trauma. And I guess, Dr. Rao, this is something we still use today, but can you kind of talk about the origin of this or how this idea came about?
Well, I can tell you exactly. I still remember the first patient that we did this to, and it was done by Dr. David Teague and Dr. Winston Warm. Winston was a resident, and Dr. Teague was a fellow. And they were on call one night, and a patient with a C-type injury, really unstable hemipelvic injury with an open perineal injury came in, and the patient wasn't doing well, and they were asked to provide some type of therapeutic intervention. So they got the idea of encircling the patient in a sheet. They had seen Dr. Mike Kopus use a vacuum bean bag prior to this, and so they thought that the sheet would be easier to use than the vacuum bean bag. And the bean bags worked. It was similar to the military anti-shock trousers, so phenomenon of hydraulic pressure. But they pulled on the left hemipelvis. It was the unstable side. They packed the open wound and then put on a circumferential sheet, very similar to the one you see here in the diagram. This is just, of course, just a patient who's not in trouble. This is just a normal patient for having another surgery. But the post-sheet X-ray was pretty phenomenal. It was, you could still see the injury sites, but they were almost perfectly reduced. And that was for sure the first time I had ever seen anything like that. And so, we then actually did some things to actually hold that reduction by making some working portals, and the working portals and everything sort of came right in that same moment. But the sheet, the very first one, was a pretty impressive, very ill patient who I think survived and did well as a result of the actions of Dr. Warm and Dr. Teague. And then Dr. Falikov and Dr. Woodhouse were residents of ours about 10 years later, and they had seen several patients have this. They had seen it being used. Dr. Falikov was a pretty aggressive writer, and Dr. Schildhauer was a visiting fellow from Germany. And so between the three of them, they were able to come up with this publication of a technical trick to just show the application of the sheet. But we had been doing it for probably 10 or 11 years by the time they published this paper.
Wow, that's great. Yeah, it's such a simple maneuver that's had such a profound effect. That's really amazing.
Well, it became pretty much our standard of care. We never bought binders or anything like that. We didn't follow into the binder fad. We just kept using sheets, and our paramedics would keep coker clamps and sheets on their buggies, and it just became sort of the standard of care for patients with identifiable unstable injuries. And we were part of the paramedics education, and we had an annual event with them to where we could go over different cases and things like that. So we were working hand in hand with our EMTs and paramedics.
Nice. Then I like these pictures, applying the sheet just for the junior fat residents on this call. Any common errors you've seen in sheet application, ways to avoid it?
Well, we've tried a variety of different ways. Sometimes people don't have clamps, and so I don't think it's a mistake, but it's a windlass technique where you can just actually knot the sheet and then use a stick or some type of a long device to turn it down and to apply pressure. Sometimes that makes a knot in the front that can cause some pressure areas that we have to sort of resolve. If you apply it smoothly like this, from crest down beyond trochanter, it's a swaddling procedure that gives usually a good result. Sometimes when you're applying the clamps, I've seen people when they're putting the coker clamps on or a towel clip on, I've seen them get skin. I even saw one coker clamp about 5 years ago applied onto a male patient's foreskin. So you have to just be careful. Like anything else in medicine, you can screw anything up, but it's a pretty hard technique to screw up.
That's good. Yeah, definitely want to avoid some of that. And then going forward, you kind of alluded to this now. A benefit of the sheet being able to work through the portals. I love the anatomy here that you've drawn out on patients. Being with you in the OR, seeing that done in real time is great. Any thoughts about what you've done through these sheets? I'm guessing basically everything.
Well, the first one I did was actually an angiography. We had a really good colleague named Yoram Ben Menachem, and he was actually the chairman of the Department of Radiology, but he was an interventional radiologist, and so he was intimately involved in a lot of the resuscitations of these patients. And he liked doing this because he could cut a hole in the sheet to get to the groin to do the angiographic, and he could do the angiographic procedure with a relatively stabilized, or at least a wrapped pelvic ring. Doesn't mean it was stable, but somewhat for volume expanded injuries, they were stabilized, the ones with a posterior hinge. So he was good with that, which was one of the biggest accomplishments, is to get it beyond the people that have to work through it. And then the trauma surgeons were good with it because they could see the benefit of it just radiographically. They could see the benefit of it. And then the very first time I did this, we just had a patient who had resuscitated pretty well, but not well enough, and still had about a 4 centimeter or 5 centimeter gap of his sacroiliac joint. And the trauma surgeon on call that day actually said, can you just, put a screw in that, now? And I said, sure. So I went to the operating room and got the set and the drill and stuff like that, some betadine, and then went up to angio, and then actually did it using the fluoroscopy machine, which the techs were very good with. Some of the techs used to cross cover in the operating room in the early days, so we had techs that do the inlet outlet and stuff like that. So, and then when we put the screw in, the patient actually, maybe I would say about 4 or 5 minutes later, started having a real positive clinical response to the compression that was applied to the sacroiliac joint with a simple lag screw. I wouldn't prefer to do it in angio. I think that's a harder environment than the operating room. Especially, you have to make sure you have everything that you need. But it can be done. And anyway, that's how that started with the doing the sheet, doing the working portals. Mostly it was just working with Ben Menachem and then taking him down to the OR. But then also inserting. Really early on, I think it was maybe the 3rd or 4th patient we had was this guy that we put the screw in as well.
Very nice. And then question, a lot of patients coming in with binders now on. Are you switching them out the sheets often, or does it just depend on your plan for them?
Well, unfortunately, I think we see, so if it's on acetabular injuries, we take them off. So we do see binders on intertrocks and binders on femoral necks and binders on femoral shafts. So we see binderaholics. So the binder comes off of the injuries that aren't necessary. And then if the binders aren't having a good reduction, and we think we can get an improved reduction by applying a circumferential sheet, then we certainly will just take off that functionless binder and exchange it for a sheet. But if the binder's done a great job, then we'll just leave them in the binder. And then if we really need that, if we're trying to just hold that reduction, we'll try to cut around the binder and at least get a frame on or some Ramus screws or something. But it's harder to cut through the binder, especially if it's up a little bit higher than it's advocated for. If it gets up into the flank area, it's a little tough to work around. The sheet's pretty easy, so we prefer a sheet. But and if the binder's not functioning, exchange it out. And then if the binder's working, try to work with it. If not, then exchange it out.
Very good. And then the last paper I want to highlight is anti-shock iliosacral screw. You kind of talked about it, but I love this paper for the images, especially those in the lower left, seeing how these screws have such a powerful effect. What has been your experience with these?
Well, this is usually about only 2 or 3 patients a year at pretty busy centers. So when I was in Seattle, we'd see two of these maybe a year, and then same thing here for the last 10 years in Houston. I remember exactly this patient because you can see this patient's got a perfect injury for a resuscitative screw. He's been applied into a sheet. He's been to angiography. You can see the embolic coils already, and the patient is still not doing well. And you can see we've even applied an anterior universal compressor to help get the reduction. And even with all of these different things being applied, we still have this fairly dramatic gap of the SI joint in a patient not doing well. And so this is a patient that I think has a really good, and this guy actually had a really dramatic, probably 2 or 3 minutes after we applied the posterior ring, or for sure within 5 minutes, this guy's entire clinical course reversed into a very good way. And you can see the reduction is not quite perfect, but in that situation at that time, this is a really good technique. You can do this with a C clamp. You know, the pelvic anti-shock clamp can also be used for this, and a lot of people may want to use that or prefer to use that. But that device, we tried that in the early 90s and late 80s, and it's a little bit cumbersome. Sometimes it's hard to find, and sometimes it's a little intimidating to apply. And we still would, you know, say put it on in angio. You know, if you're going to do it, at least use fluoro to make sure that you're docking it where it's supposed to be. But I would prefer internal fixation over that thing. With the early experiences we had with that, it was okay, but just a sleeker, simpler technique is just to insert the lag screw, and then the reduction's good. Add the fully threaded screw just to hold it. People say, well, maybe I'm going to burn up my pathways if I want to revise it to an open reduction. You can always find another pathway, especially after you do the reduction. It'll be a little different, and I haven't had that be a problem, but I could understand their concern. It just hasn't been a problem.
Very good. I'm going to stop sharing the screen here. So appreciate you going through those papers, giving us some inside information. Obviously, there's a lot more of the pelvic resuscitation. I know you give a lot of great lectures on these. Where are any major takeaways that you want people to know, or some just real basic principles of pelvic resuscitation that the audience can take home?
Well, simplistically, you've got to show up. So the first thing is you've got to be prompt to realize you're a part of the team and a critical part of the team. The next thing is to keep things very simple. If there are significant perineal open wounds, pack them with a Kerlix roll or two. Just make Kerlix rolls work great because they're long, they can be wrapped, and they can be packed. And even if you have to do two, you can tie them together. So they make fairly great packing material. And then once you've got the wound packed, then you'd want to, if it's a perineal wound, you'd want to put on a binder or a sheet, whatever wrap you prefer to use. I prefer a sheet, but it's pretty much see them and get there quickly. Pack the open wounds, wrap the pelvis of some way, and then make sure that the environment the patient is warm, so they don't get coagulopathy from cold, and then start to try to work with the resuscitation. Sometimes you're the best person for putting in the proximal tibial bone marrow port for resuscitation. Sometimes you need an intraosseous line, and people don't know where the proximal humerus should be catheterized. People don't know where the proximal tibia is weakest and can be catheterized. So a lot of times the orthopedic surgeon can also help, not just with the packing and the wrapping and but also with the filling and the warming. These are all critical elements of it as well. And then once you get it all settled down, if they're still not doing well and they have an injury that's good for still some type of percutaneous screw, whether it's ramus or posterior ring, put that in. I wouldn't recommend doing it in angio. I'd take it to the operating room to where it's more routine, but it just depends on the environment that you practice in.
Very good. Well, thank you so much for taking the time to talk about those articles. Obviously, great techniques, ones we still use today, and have made a big effect on patient care. Appreciate it.
Really good. Thank you very much for inviting me, and if you have any other questions, let me know.
All right.
Awesome. Well, thanks to the faculty authors as well as the moderators that conducted those interviews. Those were great. 3 great articles plus some bonus articles from Dr. Size and Rout. So those were awesome. Thanks, everybody. Thanks for joining. We had some good questions in the Q&A, and I guess I want to kick it off with one of the questions that was just asked. I'll kick this to all 3 authors. Have you guys had pushback when using the sheeting technique in terms of metal artifact as it pertains to the clamps that are applied to the patients, or have you guys switched to using like plastic clamps or something because it's a problem when the patient either goes to angio or goes down for imaging?
Never.
Yeah, I haven't had that issue either, but worth bringing up. Dr. Perry, would you mind telling us a little bit about how your transition has gone at your center from a center that was pretty heavy in terms of open pelvic packing, and you said now over the last year has really gone away from that. Did you guys get better access to an angio suite, or was this simply just a change in protocol after looking at the data?
We did have some new radiologists join us who were like very excited about getting involved. I think one of them actually came from Houston. And so that helps. We also had a couple trauma surgeons leave that were, who were performing most of the packing. And then, really just having the collaboration between groups of, just being able to have meetings with these guys and talk about the complications and make changes is really nice to have. And I think that spirit has kept this research direction going here for the last decade or so.
Great. I have a question just in general for everyone. So at our institution, we do a lot of pelvic angiography, but the timing and indications haven't been really well protocolized here. Additionally, have you seen issues? I know it's quoted in the literature, like missed vessels, missed, chances to embolize, people having to go back. I know they quoted maybe like 10%. Just wondering if anyone has any personal experience or anecdotes on that.
Yes, we published a paper on that with Eileen Bulger. I think Eileen was the first author, and it was maybe 20 years ago, but we looked and we found patients that on the second angio had lesions that were missed on the first. But I think Eileen Bulger was the first author on that.
Oh, I think you're talking, Dr. O'Toole, but we can't hear you. Or is it just me?
I can't hear either.
Oh, sorry.
It's just something you should always remember. I don't know if Bob's mic is not working, but it's just something that
1, 2, 3.
Go ahead, Bob.
Oh, you hear me now?
Yeah.
Oh, sorry. My first time on Zoom. Yeah, so I was going to say that rationale, right, is one of the things you hear the interventional radiologist say, is what Dr. Rauch just says. They say, well, look, this is a snapshot in time, and I was called in here because this patient was really sick, and now the angio is negative, but I don't know if it's going to be negative in an hour, so I better embolize something. And or I'll just, there's nothing arterial here, but I'm going to decrease the pressure head going in. So I think you get really different opinions from different interventional radiologists about what they want. And of course, the trauma doctors, we get involved and the trauma doctors get involved. So I think there's probably a lot of differences in what people do. When we looked at our perception is if they go there, they're in the barber chair, they're getting a haircut. So if you bring them in, they're going to embolize something. But actually, when we looked at it some years ago, only half the patients actually got something. So there were lots of patients, even though our perception was they all got it, that they went in, got an angio, and they said, no, it's negative. They didn't do anything. Maybe that's a bad idea. As Dr. Rauch saying, maybe that's not smart. You should embolize something.
One of the things that helps also is if you do find a negative angio in your first run and the patient's still being actively resuscitated, just leave the catheter in. That helps so much, because then if you are still having problems, then they don't have to instrument the artery again. It's just the catheter's in, and then they can take a second look at it an hour later or 4 hours later or 10 hours, whatever it is. There's a lot of value in maintaining the arterial catheter during that initial phase until the patient planes out.
Is that something that you're communicating directly with the vascular interventional radiology team, i.e. you're in the room, they have decreased pelvic volume, they get an angiography, they think it's negative, and you say, hold on a second, we've had some of these that have needed a repeat angio and have come back positive, so maybe we leave the catheter in, monitor how the patient does, and if they continue to be hypotensive or show signs of under resuscitation, we bring them back for a second look.
Sure, those are conversations. That's like 1994 conversations. So those are the conversations we were having in 94, and we shouldn't be having those today. But if you have to have, you have to say and communicate whatever you need to say and communicate to advocate for your patients. And so if your angiographers don't know that, or the trauma surgeons don't know that, then you have to help educate them. It's just like hanging around and putting a warm blanket on someone or sticking an intraosseous catheter in. So whatever you can do to help, is always very helpful. So if that's it, that's communicating with people who just may not know that, that's fine. But in 2023 in North America, I think people know that, but maybe they don't.
Question,
It was novel in the 90s.
are a lot of people doing TXA for these patients as part of their resuscitation, especially if you're taking them to the OR or anything, or is that part of like their transfusion, massive transfusion protocol when they're coming in?
I'll let someone else answer.
Yeah, I mean, we're people are getting TXA at our site still. I think, I mean, as I said in that little interview, I'm not giving anyone TXA, and I'm not resuscitating them when they first come in. That's not my role in it. But you know, there's been some controversy about that, even though there's big trials on it as to exactly who benefits from it. And they're, you know, they're sort of trying to find, like anything, trying to find subgroups of patients that benefit from different types of resuscitation. TXA is certainly one of those things that's gotten some controversy in the trauma resuscitation community.
Yeah, it's controversial in our center for sure. They can get it acutely, but if it's delayed at all, meaning the day after, then it's a no-go from the trauma team. They do not like it.
Yeah, that's kind of the same. University of Utah. It was after about 4 hours, it was a no-go from the general surgeons wouldn't allow it.
Even if you're going the next day for like a open reduction or something in the OR, that's interesting because we'll give it just a loading dose if we're taking them to the OR, do like an open approach.
Yeah, they were pretty against it.
Yeah, I mean, that's the whole spectrum that's represented here, right? Our general surgeons are part of a multi-center trial for pre-hospital TXA. So, I mean, I think that you can see all the different things represented here, you know, that you've got centers here that people are way aggressive on to the point of doing it pre-hospital and then asking for multiple times in hospital. That's us. And then you guys actually have pushback from your people. So I think Dr. O'Toole's right. I think that we were still searching for what kind of the right fit for this is.
I think if you take a look at the data, that's the pre-hospital data is the most convincing for TXA showing benefit in mortality. That's CRASH 1 and 2 clinical trials that have showed mortality benefit to pre-hospital TXA. I think any TXA trauma patients at least receive after they hit the front doors of your hospital is been slightly controversial. So I think that there's still some room for growth in terms of what we'll learn and how TXA will be used moving forward for the hypotensive patient. Dr. Rout mentioned the use of a C-clamp and his early experience with that. That's something that was being used intermittently while I was in fellowship. So I know Dr. O'Toole has some experience with it. I was wondering if the two of you could review what a C-clamp is. Dr. Rout sort of touched on it in their video, but I think that there's going to be some people participating tonight that aren't familiar with it. And then maybe give us some thoughts on like the early experience Dr. Rout had and maybe more modern experience Dr. O'Toole's had, and maybe some drawbacks of the use of the C-clamp.
The anti-shock.
We'll start with you.
It was just a device that was designed by Reinhold Gantz, and then Bruce Browner had a clone of it. It was a device that was applied percutaneously bilaterally to the posterior ilium and then compressed. And Dr. Browner's was circular in shape, or 2/3 of a circle in shape with a big hinge bolt in the front. Dr. Gantz's was 3 sides of a square and more like a chair clamp. They're both, I would say, should be applied in angio. If your patient is sick enough for anti-shock clamp, you should probably be in angio, and you should use the fluoro to site where the ilium is. I think people have a lot of trouble. So when we first started using it, we had clinicians that were trying to do it in the early 90s in Seattle, and you know, you'd find it through the greater sciatic notches in the colon, and this is not a good place for a clamp to be. So it's just it requires precision to be applied. Those are usually not such precise times. And we rapidly evolved to circumferential wrapping and actually had a much better experience with that. So I haven't seen a pelvic anti-shock clamp actually applied to a patient in, I would say, 25 years.
We don't use a C-clamp in the posterior ilium, and I've never done that. We have had some experience using the so-called T-clamp, meaning putting that same clamp on the greater trochanters, and those are described by Archdeacon like in 2006. And we started messing around with it a little bit when Reboa got very popular. And what we thought we would do is that it would be put on in the emergency department by our residents, instead of putting on the binder or whatever, and just like they put in traction pins and all sorts of other stuff, they would apply this thing and then we use binders, but whatever, get the binder, the sheet off, and then have it. So we never did that. So we've always applied it in the operating room. And we had a time period of a few years where we were experimenting with it. And I think it's okay. I'm not a super big fan, and I tend not to do it. I think there are technical problems with it and with managing the patients with it on. It is very powerful reduction tool, just like a sheet or a binder is. It's sort of embarrassingly good reducer of the pelvis, as Dr. Rott was talking about before. But you gotta have one. It's not technically easy to use. We don't have the rotating one. We have the three sides of a square, as Dr. Rott described. And if you don't if you're not sort of collinear on that other axis, it wants to bind as you reduce it. It can be very difficult to actually enact a reduction if you have the things off axis, and also the femurs move. And so you just put pins into the femurs. Well, the hips can rotate. So what happens when you try and rotate the hips and you've got something in there? But the vascular surgeons loved it because they didn't have to mess around with the sheet or mess around with the binder, right? You just put that thing on there, and then unlike an X-Fix, which I think is mechanically quite bad in this situation, this was mechanically pretty good. And you could, keep the pelvis kind of reduced. We do it occasionally now, but there was a time period where we were experimenting with it when Reboa was, we were first using that.
Yeah, thanks for bringing that up. I think for those unfamiliar, reading the papers on the T-clamp is another application of that device that can be helpful. For all three faculty as well as the moderators, I'd like to ask you all, how long are you willing to leave the patient in a sheet or a binder? And if patient is not clearing to get to the operating room for application of an external fixator or limited internal fixation of the pelvis, what are you doing, or what are those discussions like with your general surgeons? Because I imagine everyone's encountered this where somebody's got a pelvic ring injury, they're well reduced in a binder or a sheet, but they're getting resuscitated in ICU for multiple days, not clearing. So how long are you leaving them in, and what are those discussions like? Dr. Perry, why don't you kick it off? Then we'll go to Dr. O'Toole, Dr. Rao, and then we'll have Dr. Working Size and Callum all weigh in on this, because I think this is a question and a topic that comes up at my center quite frequently.
We can't hear you, Josh.
Sorry, first time on Zoom as well. We routinely move them at 24 hours and expect if the patient is resuscitated, which a majority of them are at that point. But I'd say most of them are going to the operating room the next day.
Most of ours come off in the first day, but some patients, the patient you're talking about is, okay, well, what if, you can't just take it off, the patient's not doing well still, and nobody wants you to operate on them, do like a big surgery because they're so sick, and what do you do? So I will leave it on sometimes. I have not had great experience with just uniplanar external fixator in the front, either Hanover frame or Resuscitation frame or Pittsburgh frame or whatever you do. I feel like you can get it reduced, but I think mechanically it's not so great, unlike the circumferential application of pressure that a sheet or a binder does, which tends to really reduce things. I just think an X-Fix, it can be tricky to reduce it, but it really struggles to hold it because it's just so far away. If you take an X-Fix in the OR, as I always say, in a pelvis and look at the geometry of it, and put your hands where the pelvis is, and then try and move it, it like moves all over, right? Because it's not, and so it's great as a rope, but it's not great to control something in 3 degrees of freedom or 6 degrees of freedom. So I think in those cases, what Dr. Rout said is, if you can get in there and actually fix something and reduce the pelvis with screws, we've definitely gotten more aggressive over that in the last 10 or 15 years for sure. And it used to just be something we do only in, extreme situations where the patient is really biting it. But now we're much more inclined to do that earlier on and get them out of the binder. But I have not had a lot of experience with soft tissue problems. I know people talk about that, but it's not like, I certainly don't, for me, feel like the clock is ticking and at 25 hours, all the skin's going to die if I don't get the binder or the sheet off.
No, the sheet doesn't hurt them anymore. The sheet's not going to hurt them like the car that ran over them. So if you think that the sheet is hurting their patient, if it's a functional sheet and the patient needs it, you leave it on. It's just like any other type of splint, brace, traction, anything you do. If your patient needs it and it's helping your patient, you need to leave it on. They're not going to die of skin. They're not going to die of blistering. They're not going to die of these things. And if a car ran over them, the sheet's not causing a problem. It was the car. So I just think that you leave them on as long as they need to. Sometimes you have to replace them because they get foul, but usually the patients can be made well enough to go to the OR. And if you've got a good reduction, you can put some working portals and put some screws in a frame on, or Ramus screws, whatever it is, and give internal and or external fixation and then get it off. So it's still a potential problem, but in the early 90s, this was much more of a problem than now. People are better, with resuscitating and getting patients cleared. And I think the trauma surgeons understand the value of, a reduced stable ring much more in 2023 than they did in 1983. That's for sure.
And one thing that brings up about that X-fix instability, when we changed our protocol, we switched from X-fixing and pelvic packing to binding because of what Dr. O'Toole was saying. It's just the X-fix, we have so many pelvic rings that are just very sloppy, not controlled, and I think the binder just does a better job. So that's another change to our protocol.
I'm sure you guys have all had these experiences with your general surgery colleagues, and that sometimes, they're a little slow and reluctant to let go of history. There's a couple of salient patients at our center from the time of non-selective angiography that developed, wide skin necrosis, and that was attributed to sheets and binders in different cases. And so we've sort of had to come to a compromise because we kind of can't get people to agree on stuff where, if we sort of do things, then if we keep sheets or binders on, we get to a protocol of it's like Q12-hour skin checks where we go in and the orthopedic team internally rotates the legs and holds the knees together, and we open up the binder and go like, oh, good, the skin's not dead. And then we close it back up. And so that's what's necessary to keep the peace sometimes. And there's only so many committees you can go to try to change, 10 to 15 years of history. So that's where we're at. But largely we can keep things on for a long time. And I agree about the X-fix. I think the X-fix sometimes is ornamental. It may not provide anywhere near as much control as something that goes all the way around. So I think it's just like keeping, like all these things, it's lines of communication, and probably the best thing you can do to help is develop good relationships with those people so that you can talk to them and, convince them to give you a window to give them a stable pelvis to resuscitate against.
Yeah, I agree with that. We've done, we keep people in sheets. I've had people in there 3-5 days. We change the sheets when they get foul, but it's rare. I think it's been 2 patients. Otherwise, they've been getting to the OR quick and keeping the sheet on and putting screws in. It's been overall beneficial for both parties, both for general surgery trauma because it gets them taken care of, and then I don't have to worry about this patient being a sheet in the ICU. And then it's something that we've stabilized the pelvis, and so their patients, in a lot better position.
And I think to answer your second question, Lucas, is if patients aren't clearing, I think it's what Dr. Rout says, time to advocate for your patients and for you to kind of start looking into why aren't they clearing, and for you to have conversations with, I think, attending. And I think that happened a lot at Utah. If people aren't clearing, it's not, well, general surgery said they're not cleared, and then you move on to the next day. So I think it's making sure you're advocating for the patient and looking into why they're not clearing.
Sometimes you just have to tell people what you do. And, there's a real value in being able to just inject some common sense into these scientific situations. Just common sense is really a good thing to have in these environments. And I just can't overemphasize that enough. And sometimes the surgeons or the neurosurgeons, they need to know that you're going to do something percutaneously and you're not going to lose 2 liters of blood like the case they saw 6 months ago. There was a both column that bled a whole bunch. They don't know what you do. So, or they may, but you just have to refresh their memory and say, look, this is a 1 hour percutaneous. I'm cutting some holes in the sheets. I'll be through in an hour, and no kidding. But then you have to do what you say you're going to do. You can't say I'm going to take an hour and do percutaneous and then say, oh, while we're here, let's go ahead and nail the tibia or whatever. So you've got to at least build the trust by telling them what you're going to do and then doing it.
Yeah, that's great. Sage advice from everybody. Thanks. I think the communication is key, and helping the teams understand exactly what you're going to do, because oftentimes what they expect we're going to do is a lot bigger than what we're actually going to do, particularly in these scenarios. So I'm going to share my screen really quick and we'll wrap it up with some slides here. Awesome. So a link to this recording will be sent out through Zoom 24 hours after the conclusion of this session, so you all can look for this tomorrow night. Here's an upcoming look at journal clubs for the next 3 months. In September, looking at infection. In October, operative treatment of clavicles, and then back to the pelvic ring, but this time discussing another controversial topic, geriatric pelvic ring injuries. So this is my AO. This is a great app that everybody is able to access. Would encourage you guys to use this. It will help you join the Trauma Journal Club discussions, and also a plug for the MyAO Casefolio, which is basically an on-the-go clinical portfolio that helps you organize, store cases, and securely share them on your AO network. And that's it. Thank you, everybody, for joining tonight. We're basically right on time. Super grateful for the moderators as well as the author faculty that joined us tonight to share all of your wisdom and knowledge. Thanks, everybody, for joining in. Hopefully this was a fruitful experience and a learning activity for everybody. I really appreciate everybody's time on a Tuesday evening. So thanks again. Have a good night.